virtual seminar today. My name is Jesse Gutnick. I'm one of the bariatric surgeons here, and we've got a great panel for you. We've got Jamie Sarver, who's both one of the nurses in our department and a patient, and she's going to give her story as a patient, and is also available during the Q&A for a perspective as a caregiver. Karen Schulz, who's one of our obesity medicine providers, myself, and Dr. Ricard Corcelles, who's another one of our excellent bariatric surgeons. So a quick agenda. We're going to hear Jamie's story. I'm going to talk about the way that weight loss surgery is effective. Dr. Corcelles is going to talk about the safety profile, and Karen Schulz is going to talk about what you can expect in our department. At any time during this, please submit questions to the chat. Send it to all the panelists so we all can see it. I'm going to have a moderated session at the end to go over them. So with that, I'll let Jamie take things away.
Hi, everybody. Thank you so much for joining us today. I really appreciate you guys coming and just hearing my story. So I am a nurse that works in this department. I work with a medicine team. And about 5 years ago or 3 years ago, I decided to have bariatric surgery. And since then, I've found that it was really important for me to share my story just to help other patients that may be questioning surgery or not sure if they want to move forward with it. So next slide. So this is some pictures of me just over the time, the last 3-ish years. So if you see the picture on the left, that was me in 2019, where I was at pretty much my highest weight. And then the picture in the middle is me about 1 year later after having the gastric bypass. And that is my surgeon, Dr. John Rodriguez. And then the picture on the far right is actually June of last year, me seeing him again. So pretty much every time I've seen him, I've just kind of made a point to make sure I get an updated picture. And so he's actually currently working with us at the Abu Dhabi location. So he's not available to do surgery here at Cleveland Clinic main campus now, but great surgeon and a great part of our team. All of our surgeons are excellent. So next slide. So here's a little bit of information regarding my case in particular. Prior to surgery, at the time I was about 34 years old. My highest weight was 253 pounds. I really didn't have a significant, extensive history or medical conditions related to obesity. I really just had polycystic ovarian syndrome as well as infertility. And I really knew that based off my family's history and what was going on with me, mostly just like muscle aches and joint pains and things like that, that I really needed to start thinking more about how to take care of myself and make a change that's going to be lasting and permanent. I knew of bariatric surgery before I started working in this department, but it was just something that was kind of in the peripherals. Like I knew about it and I knew that that was like something that people could do. I just didn't know how to attain that for myself as I, you know, grew and came into this department. I kind of actually figured out more about how bariatric surgery works and just kind of extended my knowledge for it. And that's how I wound up making my decision. I had tried diet and lifestyle interventions prior to considering bariatric surgery. However, they just really, even medications were not as effective for me in losing and maintaining weight loss. And so I finally just kind of got to the point where I just needed to do something that was going to be lasting for me and help me to make that permanent change. So my actual surgery was the gastric bypass, the Roux-en-Y gastric bypass. I had that on December 13th of 2019. My weight the day before surgery was 233 pounds. I'm currently about 125 pounds. So I've lost a significant amount of weight since bariatric surgery over the course of the last 3 years. My actual time in surgery was about 1 hour and 20 minutes. And my total hospital stay was about a day and a half. That's going to change depending on the patient and how they're doing postoperatively. There's not a race to get out of the hospital. Some patients stay over one night. Some patients need that extra night. We really just want to make sure that you're safe to leave and that you're able to tolerate fluids, that kind of a thing. So it just depends on how your recovery is. And then I was probably taking pain, like real actual pain medications for about 3 days postoperatively, where you have that immediate, like I just had surgery on my stomach pain, and I needed to stay on top of the pain. But then after that, the pain started lessening and I was really able to just take extra strength Tylenol. And I really only needed that as needed, like if I was up and moving throughout the whole day and I just needed something to kind of help take that edge off. But it really wasn't painful other than just kind of a little bit of pulling, pushing, pinching, like when you're kind of moving around a little bit. I was moving and walking pretty well within 3 days of surgery. Literally from discharge, I went to the place that we were living, and it had 4 flights of stairs. And so my room was on the 4th flight, all the way up in the attic. And so I was walking up and down 4 flights of stairs pretty much, I don't know, 2 days post-op. So it wasn't too difficult. I was back to work in about 4 weeks after that, and I had no issues since then. So next slide. So I just wanted to give some information about like kind of like my weight over the course of the 3 years and even some of it beforehand. You can see this is a pretty far, like essentially the whole time I've worked in this department. So from January of 2018 to January of 2023, this is my weight graph. So you can see I was, at my highest right before surgery, that 250-pound mark. And then I had done some work to try to lose a little bit of weight. And you can see right before surgery, and then 6 months post-op, that's where I have that most significant and well-defined drop in my weight. And then it kind of starts to even out between 6 months and 1 year post-op. And then even more so between 1 and 2 years post-op, you kind of start to just plateau and level out and get to like what your body's new weight thinks it's supposed to be. And then in addition to that, kind of more recently, I've been working towards kind of working on those extra steps to continue my weight loss. Next slide. So I like to talk about some of my post-op milestones. These are just important factors within that first 12 months that are really noticeable and like key for most patients. So between 2 and 4 weeks post-op, you're still on a liquid diet. So you're really not eating anything. Protein shakes are essentially your main source of nutrition. So it can be kind of a little bit daunting because you're kind of bored. Most people like want some variety in their diet. And so, you're not really hungry, but you're kind of just getting sick of the protein shakes, but you need to drink them, and really just working to make sure that you're meeting your protein and water goals so that you can actually stay healthy and not dehydrated and things like that. So that's the only difficult between that 2 to 4 weeks is nothing's really tasting great. There's really just you're eating, drinking to make sure you're maintaining your nutrition. Some other important things were getting up and getting moving during that time. Most people are off, usually get like a FMLA or a work release for about 2 to 4 weeks, just depending on the patient and what you do. But I really used that amount of time, that 4 weeks that I had off, to really make a concerted effort to start making some changes in focusing on like, how is my new diet going to be? What do I need to do to make sure that I'm getting water in? And just really starting to make sure I'm setting a new routine, making sure I'm taking my vitamins on a daily basis, and really getting those under control before I go back to work and start bringing all these other things on. At 1 to 3 months, again, you're pretty much going back to work at that point. You're hitting your protein and your water goals daily. You really know what your protein and water goals are and the reasons why you may or may not have gotten them that day. Sometimes you may have a little bit of nausea or have a difficult time trying to get some of that water, or sometimes it's the protein shakes. It just kind of depends. But really, you should be able to hit both of those on a daily basis. And then you also, at this point, at 1 to 3 months, even at 1 month, you're really starting to notice your weight loss. Not just you, but others are noticing it at this point as well. And even at 1 month post-op, my activity level was so much more increased. I mean, I was going home from work prior to having surgery, and my feet, my ankles, things like that were hurting from, working the floor and being up and on my feet all day long. And even at 1 month post-op, when I came back to work, just that amount of weight that I had lost, I was already feeling like I was able to come home from work and I wasn't having like, stiff joints or, things like that really affected my, ability to go home and just enjoy my time instead of coming home and having to like rest my feet and just sit down for a little bit. I, was able to still go out and do other things and go on walks, and my activity level really had increased by that point. At 3 to 6 months post-op, I like to say this is when food is finally your friend again. You're able to actually kind of have a little bit more variety. Some more things start being incorporated into like your diet. And so you're able to, and you have a little bit more room. Some of that internal swelling has kind of gone down. And so you're able to kind of eat a little bit more, and you're actually able to enjoy your food. You're not having like hunger cravings or anything like that. You can only eat a certain like small amount, but you also are able to kind of enjoy how much you're actually eating of it. You're also still really losing weight at a good pace during this time. And your activity level is just continuing to improve at this point. At 6 to 12 months, this is when you kind of start slowing down on the weight loss, but you've still achieved a significant amount of your weight loss. I believe by the time I was about 6 to 8 months post-op, I had already lost like 70 pounds. So a good amount of my weight was lost, but I noticed I was starting to slow down on how much weight I was losing. I was meeting my protein and water goals daily. At this point, I was also noticing how significant the change in my cravings were. I always tell people that my son's birthday is in June. And so I was exactly like 6 months post-op for my son's birthday. And that was the first time, and I think his entire 13 years, that we threw out like half of a cake because none of us even ate it. And I mean, the cake was literally just sitting at the table and it just went bad. And that was where it was like that noticeable point where I was like, oh my gosh, this has been accessible to me this whole entire time. And my mind is not even focused on this. I don't need it. I had a bite when we were celebrating my son's birthday, but then after that, I have not even thought about it since. And so that was something that was significant for me at that point. And even still to this day, I really don't have cravings for those types of things that I used to have anymore. And then also another important factor is at this point, I'm really comfortable with my anatomical changes. So for me, I had the gastric bypass. With that, you kind of have some issues depending on some of the things that you can eat. You can have some effects from the way that metabolizes in your system. And so knowing that and figuring out how much food I can actually eat, and knowing what did I put in my mouth that I maybe shouldn't have that made me feel this way, you're comfortable with that at that point. You kind of know what to do and what not to do. Another important factor was your intimacy, your confidence levels, your relationships with your partners and friends. A lot of that changes during that time. And so even my relationship with my husband, I could tell there was like a shift. Like, he was fine with me having bariatric surgery. He was supportive. He didn't think that I needed it. I needed it for myself. And that's why I made that decision to feel better about myself and feel better about my confidence. But it was funny that by the time I got to 6 months post-op and my husband had seen what a change it was doing for my health, and I was able to be active and all of these types of things, even he kind of came around to it where he was like, oh my gosh, like, you look great. Like, you're out, you're doing more things, you're so active now. We go walking, like doing all these things that really we weren't really doing before because our health was kind of not the best. And so that really kind of, I feel like, helped our relationship. And then also you really notice the non-measurable goals. So I kind of talk about these types of things where it's not defined by the number that's on the scale, but things that you wouldn't have thought of prior to surgery. So like putting on a sock while you're standing. That's something that it's funny, but it's true. Like, I didn't have a good sense of balance before. I noticed that as I was losing weight, my balance was getting better. Just getting up from the floor was better. Sitting in the car, you're not as cramped. So all of those types of things where you don't really notice it until that change happens to you, then it becomes significant. So next slide. So now that I am past a year post-op, I'm kind of in this phase where it's more of just maintaining the weight that I did lose. And so that's actually really important to talk about, because you're kind of given this tool to help you to lose weight, but you have to kind of maintain that investment in yourself. And so for me, even still to this day, at 3 years post-op, I'm mindful of how much sugar I put in my body at one point in time. I have, the gastric bypass, so you can have some side effects from getting too much sugar at one time. It can make you feel a little sick. So I still make sure it has to be less than a certain amount of sugar of something that I'm eating, or I half it, things like that. Also making sure that I'm getting enough protein and water in the day. That's really important. Even still to this day, I nutritionally just can't eat enough food to hit my protein goal on a regular basis. So usually I'm winding up having either a protein bar or a protein shake or something that's got a higher amount of protein in it. Like they have like the protein yogurts, things like that are going to give me that extra boost of protein that I know that I need just so that I can reach that goal. Exercise, it's really important. We all of the providers I know talk about making sure that you're exercising and starting weight resistance. The sooner you start, the better. I mean, we go round and round on this on a regular basis with our patients, and I will be the first person to admit I have told patients that, and then I had bariatric surgery, and then I was like, oh my gosh, I'm losing all this weight. I don't need to exercise. But then once I hit about 6 months post-op, that's when I started noticing that first slowdown in my weight, and I started getting nervous, like, oh, maybe I'm not doing enough. And I'm an active person, but I really wasn't doing that like formal exercising. And so once I started slowing down on my weight loss, that's when I actually incorporated that. And once I show the next slide, I have some pictures of this, why it's so important, because that change for me, I realized I should have been doing this a lot sooner, because this really helped me to not only lose weight, but also to build that tone and replace that muscle loss or that fat loss with some muscle and making my muscles a little bit better. So I just always try to encourage patients, as soon as you get the okay from your surgeon to start exercising, exercise. And the resistance training is so important to help with that excess skin and things like that you could potentially get. The next thing is just continuing your daily vitamin regimen. I was on vitamins before I had surgery. I was actually on some other medications before I had surgery. And so I switched out that I still continue a daily vitamin, but I also don't have to continue the medications that I was previously on. So for me, that, I just want to always make sure that I'm taking my daily vitamins. There's bariatric vitamins that are specifically formulated for bariatric surgery patients. And that way you can make sure that you're getting enough of the nutritional vitamins that you should be getting. And then the last thing that I talk about is keeping up with your post-op appointments. Here at our institute, we really push to make sure that patients know that they should be coming back and following up with us. Even after that 1 year mark, you're part of this group essentially. And it's so important to continue those follow-up appointments, because there's a lot of people, I'm sure you may have heard of people that they have had bariatric surgery and they gained their weight back, or this or that or the other, and that's why they're hesitant to do it. But the biggest thing is keeping up with those post-op appointments. So if you start gaining weight or you start having issues, those things can be addressed early on and not waiting until you're 5 years post-op and you maybe regained all of that weight back or gained, a significant amount of that weight back. We want to see you back before there's the issue, so that we can catch that. So we encourage post-op visits. Initially, within that first year, there's several of them that you would go to, and then starting at 1 year, it's just annual follow-ups, and it's just to make sure your vitamin levels are all good and your nutrition's all good. You're still continuing to just do the maintenance of this. So keeping those are important. Next slide. So this is why I always say that it's so important to start exercising right away. The summer of 2020, that was actually when I was about 6 months post-op, and I had started to kind of stall on my weight loss. And so over the course of like the, I don't know, early fall, like August, September kind of time zone, that's when I started actually exercising like more formally. I don't have a gym membership. I just started exercising at my house. I have a rowing machine as well as free weights. And so I was rowing for, I think about 2 days a week I row, and then just kind of incorporating like the free weights and the weight resistance training, that I have like a freestanding free weight system in my basement. And so anytime I would go down to the basement, I would just make sure that I was doing some of the free weights, usually about 20 to 40 minutes, 2 or 3 times a day, or I'm sorry, 2 or 3 times a week. And so you can see just the difference in 1 year of exercising and weight resistance training, how that affected me. I mean, I was actually able to notice, like, for the first time, I actually have like muscles and things like that, that when I used to work out at the gym prior to surgery, like you wouldn't even notice the change. And so that made me feel less motivated, and I would stop exercising. For the first time ever, I can exercise and see a significant result, and I have ab muscles and I have biceps that, I didn't know that I had prior to that. So for me, that was really exciting. And that's why I just encourage that more. The sooner you can start exercising, the better it is for you. So I think that's it for all of my slides and my patient story. But thank you so much for listening, and I'm happy to answer any questions that you have.
Thanks so much. Thanks so much, Jamie. And I really appreciate that last slide the most, showing how, as effective as weight loss surgery is, it's one part of the tool that we use to help people get their health. The other thing that I'll note is that obviously you have an exercise plan, but some people have more difficulty in terms of their ability to move with joint pain and things like that. And in that case, we can help people with a referral to physical therapy to work specifically around and to improve those mobility issues for the exercise, most of the time after surgery, but even sometimes before surgery. And with that, I'm going to talk about how weight loss surgery works. So essentially, your body is designed to maintain a current weight, and it's almost like a thermostat. So just like in your house, if you got it set at 70 and it's getting colder outside, heat will kick on and bring your house back up to about 70 degrees. Or in the summer, the opposite happens. It's getting warmer, and so your AC kicks on and brings it back down to around 70. And your body has similar mechanisms, except they're hormonal instead of being an HVAC system. And so that's why even when people can lose significant weight over the short term, they frequently move back to their current or the prior weight. Weight loss surgery reprograms how your body manages the food, and it reprograms that hormonal regulatory system that does help both lose a lot of weight initially and maintain that. Although over time, that reprogramming slows down, and your weight maintenance, as Jamie has shown, has a lot to do with your lifestyle over the long term. So looking at some of these mechanisms, when you're dieting, your body sort of fights that weight loss because our bodies are designed more for a situation, 5,000 years ago where there was significant episodes of famine, or even more recently. So when you're dieting, your energy expenditure, when you're just doing your activities of daily life, goes down. Whereas after surgery, for the first couple of years, it goes up. Similarly, when you're dieting, your appetite increases, your sensation of fullness decreases, and then your body's hormonal stress response increases, whereas after surgery it decreases. And some of the hormones that are related to this are listed below and how they differ between dieting and bariatric surgery. The most common surgical operations are the sleeve gastrectomy and the gastric bypass. There's also the duodenal switch and revisional surgery that we offer. I'm going to focus on sleeve gastrectomy and gastric bypass because they are the more commonly performed operations. On the left-hand side of your screen is the gastric bypass. Gastric is the medical word for stomach, and so essentially we make a very small stomach out of the top of your old stomach and bypass the rest of it. That works both by restriction, so a small stomach, but also by bypassing that stomach and the first part of your small intestine. That induces hormonal changes in how your body manages the nutrition that you take in. One question that is always asked, and so I'll just answer it, is what happens to the stomach once it's bypassed? It stays right there, and your body still makes digestive juices in it, which meet up with your food lower down, where you can see that connection lower down. On the right-hand side is the sleeve gastrectomy. That is where the stomach is decreased in its size, but nothing is done to the small intestine. That's sized over a little tube that's on the inside of your stomach called a bougie that's placed during surgery. That's that purple area that you see on the left-hand picture. And that other part of your stomach is removed. And it's called a sleeve because it almost looks like a sleeve. You can see that seam down the side, almost like the seam on a men's outside of their coat sleeve. So one of the most landmark studies among several was the Stampede trial, which not only looked at bariatric surgery in a randomized controlled way, but in particular, it looked at it in patients that had diabetes, and as it compared it to the best medical treatment for diabetes. And the reason that this is very frequently cited is because it was a randomized controlled trial, which tries to take out all the variables that you can get with just following people over time without the randomization, where half of people, you basically electronically draw a name out of a hat to see whether you get one treatment or the other. And in this, the patients that got the best medical treatment were in yellow. Sleeve and gastric bypass are in blue and orange. You can see along the bottom, it's the number of months after their randomization, and then the change in their BMI, which is the body mass index, which is a ratio of your height to weight. So you can see, obviously, in the surgical patients, there's significantly more weight loss, around 10 BMI points for the gastric bypass, a touch under that for the sleeve. This is possibly a slightly lower than you see in other studies, possibly because of the effect of diabetes. You see there is a small difference between the two operations because the gastric bypass is more powerful. But what was most landmark about this study is it also measured the effect on diabetes. And anybody who in the audience is diabetic sees these will know the A1C. And you can see that both groups, both the surgical and the medical group, has significant improvements in their A1C at the beginning, almost 2 points in the medical group and just under 3 points in the surgical group. But with that medical group, it kind of just kept creeping back up over time. It creeps up a little bit over time with the surgery, but it still maintains a really good loss in their A1C. And one sort of rough estimate of how bariatric surgery affects diabetes is often it kind of sets you back about 10 years to how your diabetes was about 10 years ago. Just like diabetes, it's helpful for all of the other health conditions that are related to obesity. Some of the most common ones are sleep apnea, blood pressure, reflux, and joint disease, obviously diabetes. And ideally, we want to prevent that from happening or stabilize and typically reverse them. And so with that, I'm going to hand things over to Dr. Corcelles. I see that multiple people are sending in questions, and please feel free to send them in as you think of them. And as a reminder, we'll look over them during the presentation and do a Q&A at the end. And with that, if I can hand things over to Dr. Corcelles.
Thank you, Jesse. I appreciate your slides describing the main operations that we are doing here. Also, I appreciate, of course, Jamie's testimonial. I think it's the best example about what we do and why we think that helps our patients. So next slide, please. I'm going to talk about safety in bariatric surgery. I think it's important to really know what do we mean about safety. Basically, we want to determine the risk of the operation, and then, which is in our opinion, and I'll show you the data. I am promising you I'm not going to be extending that much, but the risk is very small. And the other part is that the benefit over time in your health will be overall very large and long lasting. And I'll show you with some data that our group put together and published recently and a few years ago. Next slide, please. So this is a very, I think, very relevant paper that can show you and can be visually very easy to understand about why I'm saying our surgery is so safe. This paper was published, it's not recent, actually, we know that from almost 10 years ago. And this graph, you can see different operations, not only in the field of general surgery, also in the field of, let's see, for example, here, cardiac surgery, coronary artery bypass graft, an infrainguinal bypass, any orthopedic procedure such like a knee arthroplasty, colectomy, appendectomy, cholecystectomy, and hysterectomy. And here, in patients with type 2 diabetes, we compared the complication rates among patients depending on the type of operation that they did undergo. And I want you to put attention on the data. Look at our surgery, our procedure of, which is one of the main operations we do here, which is the gastric bypass, had only 3.4% of complications. And then when you look at, for example, something that you can think or you can feel that is perceived like very safe and a straightforward, easy operation, like, for example, an appendectomy, it's 4.5%. So just record that, save this in your brain, in your mind, that gastric bypass has less complications than an appendectomy or a gallbladder removal. Okay. Next slide, please. This is our own data, bariatric surgery in hospital mortality. This is a 7-year period, including more than 100,000 patients. And this study is showing the rate of death per 1,000 patients. And you can see that overall, and this is not only data from Cleveland Clinic, is data in the US, you see that overall, the number of deaths has been dramatically going down. You see that the trend of this line is to go down. And nowadays, those data, those numbers are even a little bit older on time. It's almost 13 years ago, 14 years ago, deaths were documented in 0.6%, 6 patients per 1,000. Next slide, please. And this is a more recent paper published by our partner and our section head, Dr. Aminian, trying to investigate the association between metabolic surgery, which is what we do, with major adverse cardiovascular outcomes in patients with diabetes and obesity. A total of more than 2,000 patients were recruited for the study, and they were matched, meaning that they were compared with patients that who received the usual care for obesity and diabetes, meaning non-surgical treatment. And you're going to see which were the outcomes. Next slide, please. That period of time was in between 1998 and 2017. look at this. This is another slide that I want you to memorize, or maybe even take a screenshot. So you can see that patients that undergo weight loss surgery have a tremendous benefit from the operation, in the sense that they live more. At the end of the day, what we're trying here is to increase and improve your quality of life and your life expectancy. So you see on this yellow line, those are the patients that were treated not surgically. And in the line on white or blue color, those are the patients that underwent metabolic surgery. Look at the incidence, the mortality incidence, when you compare the non-surgical versus the surgical group, how different it was over time. We reported that patients that did undergo bariatric surgery had less heart failure, they had less coronary artery disease, less arrhythmias, less incidence of a stroke, kidney disease, and finally hypertension. Next slide, please. So at the end of the day, how we can achieve that our patients live longer than patients that do not have surgery? The reason is that our operations, they work in a multimodal way, meaning that they tackle different problems in your health. We can treat a sleep apnea, we can improve a sleep apnea, we can resolve a sleep apnea, we can improve type 2 diabetes, we can improve safety for childbearing. Definitely your quality of life will be much better. Less joint pain, less back pain. Patients are able to simple things that we all do in a daily basis, like tying your shoes, driving in a more, if I can say that, in a more standard normal way. We can reduce and decrease the risk for cancer. We treat fatty liver disease. You know that fatty liver disease now is one of the latest epidemics that we are facing. This is the main reason that patients undergo liver transplant in the US. And that is strongly correlated to obesity. So we are able to reverse the natural history of fatty liver disease, liver cirrhosis, and from a potential liver transplant, and more than that. Next one, please. So obesity is also a risk factor for a more severe COVID infection. And when we compare patients with COVID patients with COVID infection that had bariatric surgery, we can see a main difference in between those that they had an operation with respect to others that they did not have. Next slide, please. And I think that with that will be all. I will let Karen Schulz, who is one of our leaders also in our weight loss program. And before I finish, I can see in the chat people is asking, where is my accent coming from? I apologize about my accent. I'm not Russian or German, as I can see in the chat. I am from Barcelona. I hope that you understood me. Thank you. Okay, Karen, thanks so much.
All right. Thanks, Dr. Corcelles. We can understand you perfectly. It's a beautiful accent. Yeah, so thanks everybody for being with us on your lunch hour today. I'm Karen Schulz. I'm one of the leaders of the program and also an advanced practice nursing provider. I'm just going to wrap up today and tell you a little bit about the program and what it's like to be our patient. Next slide. So one of the unique things about our program is we're in so many locations now so that you can receive care hopefully closer to your home. Number one, extensive virtual visits mean you can do almost every visit if you want virtually in the comfort of your home. Obviously no virtual surgery yet, but some of the patients, especially if they work with their providers in their hometowns to provide us an accurate height, weight, and vital signs, we can make this as convenient as you wish. We're also welcoming people in person. And we have several centers of excellence near you. We're at main campus here in Cleveland, to the west Fairview Hospital, the east Hillcrest, and a new office opening in Mentor, and the beginning of July is coming soon. Next slide. Okay. There's also a lot of great information out there about the Cleveland Clinic quality. U.S. News and World Report is one of them. We in the Bariatric and Metabolic Institute exist inside of the Digestive Disease and Surgery Institute, which is #1 in Ohio, #3 nationally. Main campus, you see, #1 in Ohio, Fairview #5, Hillcrest #4. So lots of great ratings by some of the best experts. So appreciate you thinking about us today. Next slide. Sometimes coming into the program can be a little nerve-wracking or confusing, so we really do the best we can to help to navigate you to your goals. Each patient actually has a navigator that's going to check and see what your insurance coverage is, what the requirements are for surgery, so that you'll feel, completely comfortable before coming in what you need to do as far as financially and also insurance requirements. Those navigators are available every week to you in a group online webinar similar to this, so all of your questions can be answered. Next slide. Also, one of our unique traits here at the Cleveland Clinic is every patient has their own team. So in addition to the navigator, you have a dietitian who's going to make sure you're completely comfortable with what to eat before and after surgery, an obesity medicine provider, so one of our physicians or our advanced practice nurses will make sure that you are as safe as possible for surgery. So we get people through these operations with some pretty complicated health issues, diabetes, hypertension, sleep apnea, just being the common ones, all the way up to people who may need organ transplant. And part of that is the careful screening we do ahead of time. A bariatric psychologist will see you to make sure that emotionally and psychologically you are as prepared as possible. If you already have a mental health care provider, our psychologist will work with that individual to make sure you are ready. Of course, the bariatric surgeon, really the core of the team at that bariatric surgeon visit, and I saw someone already ask this question, is when you and the surgeon together will decide which operation is the best one for you individually. Okay, so our surgeons will not let you make a mistake. They're going to make sure that together you select that best operation. Sometimes it's going to depend on medical issues. Sometimes it will be what you're feeling comfortable with, but that will happen at the surgeon visit. And then if you have any special needs, we have a variety of consultants, as most of you know, at the Cleveland Clinic, experts in every field that you may need. Next slide. So in summary, before we take the questions and answers, just, as Dr. Gutnick said, severe obesity is a metabolic disease. So our patients' thermostats are basically stuck at a certain weight, very, very difficult to move that thermostat without a powerful tool. Your calorie needs are very low, set point is high, and as many of you know, dieting really only has short-term results. Okay, it's not that our patients can't lose weight, it's the keeping it off part that is so difficult. And we know through years and years of research now that surgery combined with the healthy diet and physical activity that we talked about is currently the only consistently successful method to keep weight off for a lifetime. And it's no longer a rare solution. Okay, as Dr. Corcelles said, this is one of the most common general surgical procedures in America, and it has one of the absolute safest profile as far as low complications. Okay, that's all I have. We're going to open it up for questions now. We'll bring the panel back.
Thank you, and I'm going to start going through your questions with our excellent panel. Just remember, if you want to submit any more along the time, just send them to the chat and send them to everyone so we can see them. So I'm going to send this first one to Ricard. One operation that we didn't mention, and I probably should have, and I probably should going forward, is one of the people on the call is planning to get the SADIE operation. So that's an operation that's not covered by all insurances, in fact, not covered by most. But if you could talk a little bit about how that slots into the other operations that we offer.
Absolutely. Thank you, Jesse. Yeah, so the SADIES, despite it has come to the US probably during the last 2 to 3 years, it's been an operation that widely done in Europe, no? For everybody to understand, it is a simplified version of the duodenal switch. The duodenal switch is nowadays maybe the more powerful operation we have for weight loss surgery, but the counterpart of the duodenal switch is that it brings some sort of malabsorption that requires a close follow-up in our patients. Meaning that not all of them are clear candidates. The SADIES, which is a simplified version, is likewise a duodenal switch, which is based on a partial gastrectomy. We do what it's called also sleeve gastrectomy, and then we connect the duodenum with a loop of bowel. It is a single anastomosis, meaning we only have to do one connection. With this variation, the SADIES is able to reach similar outcomes than the duodenal switch with less potential risks because we avoid one anastomosis and also less nutritional deficiencies. Unfortunately, as Dr. Gutnick said, it's not fully approved by all the insurance. Some of them are recently giving us the thumbs up, and we're working on that in the future.
Thank you. And Jamie, I'm going to send the next one over to you. You had several questions directed right for you. So one person wanted to know if there were people that were in your life that were very much against you having surgery, and how you dealt with that, if that came up in your situation.
So it kind of did, but not too much. I actually started kind of planning and trying to talk to family members and just people in my close group of contacts, like warning them. I knew that this change was going to be something drastic enough that you can't really hide from that. Like you can't hide that you just had bariatric surgery. It's going to be something that's noticeable to everybody. So, people are going to ask, like, what did you do? And so my close family, I really talked it out with them. None of my family had ever done anything like that. So I wanted to make sure that they were kind of prepared. But I'm also the type of person that if I want something and it's my choice, I'm going to do it. And while I support or understand your views, that's not how I feel. And so I really felt like I needed to do this for myself. And not even coming from a selfish standpoint or a vain standpoint. It was just, I was no longer comfortable with the weight that I was at and the capabilities that I had. And I had done everything. I was at my wit's end and I felt like I needed to keep moving forward. And so for me, I made that decision and I just told people, this is what I'm doing. And I didn't leave it a question as this may or may not happen. It was just I'm doing this and I'm comfortable with this decision. And so my husband was the only person that I was concerned that if he didn't want me to move forward with it, but he also knew where I was at from a mental space and just my confidence levels and things like that, that he really was okay and supportive of me doing it. But he just really still also wanted to reassure me that he didn't need me to have the surgery, which I already knew that in advance. So we really just talked it through and I proceeded.
Thanks. I mean, I think this is obviously a super personal thing, depending on your personal situation. It's not uncommon for me, and maybe Dr. Corcelles can talk about it, where people want to come back for a second visit with me as the surgeon, with a family member or someone who's wants to learn more or get more information and talking that through. So that's another method when sometimes when people are not confident in that decision that a patient's making, that we manage that. Karen, would you be able to, there were several questions about the criteria to qualify, or are there certain BMIs that are the sort of the standard ones that are cutoffs? How do you qualify for weight loss surgery?
Okay, yes, so there is a BMI qualification. Most of those are set by insurance. So if your BMI is 35 to 39, you need to have at least one significant health issue related to the obesity. So that would be high blood pressure, diabetes, sleep apnea, being the three big ones. If your BMI is over 40, then all insurance companies that cover bariatric surgery are going to cover you from a BMI standpoint. Just to give you a little hint about who that would be, so all the government insurances and most of the private insurance plans with big employers. Okay, it's the small self-employed policies that sometimes don't cover. We also sometimes see patients with lower BMIs than 35, so 30 to 34, but those are generally not covered by insurance. But we do have some information, and the Bariatric Societies has said that for some people in the lower BMI categories, weight loss surgery could be appropriate, but that would be something that patients would have to pay for, as is currently not covered. Other criteria, I think most people meet as far as we want to make sure that you've given medical weight management the very best try. This is obviously not the first thing that people do to lose weight. And I think that's about it. Can you think of anything else, Dr. Gutnick, as far as qualifications? There's really no high BMI. Maybe that's what they're asking.
Yeah, so I think a frequent question, I think it was asked today, is there a BMI that's too high? And the answer is no. Now, there may be, so BMI is, it's sort of like age is just a number, BMI is just a number. It doesn't fully explain what your exact body type is. And so there are patients with, let's say, for example, of a BMI of 80, where their bariatric operations could not be more straightforward because of the way that they happen to carry their weight. There could be another person with a BMI of 60 who it's more challenging. And so part of your visit with the surgeon is figuring out if you need to have a weight loss goal prior to surgery. And that would typically be a relatively small amount, but an amount that's designed to shrink your liver. Because as I said, there could be somebody with a BMI of 80 where the operation could not be more straightforward because their liver is relatively small because they tend to carry their weight more in their hips and thighs and that kind of thing. So there's no absolute number of height, but you may have a particular weight loss goal prior to surgery, depending on your personal situation and how you carry your weight. Dr. Corcelles, someone asked if someone had a previous median arcuate ligament release, if that precludes them from surgery, and maybe you can talk about other prior abdominal surgery. How does that affect your decision on candidacy, or maybe the type of procedure you choose?
Right. No, that's an excellent question, Jesse. No, it doesn't prevent you for having surgery, that specific operation. Of course, we as surgeons, we prefer those patients that come without any previous abdominal surgery, because every time that you have an operation, your body develops scars or adhesions, no? Now, having said that, nowadays, most of the surgeries are done by laparoscopy, which means minimal invasive surgery, and that doesn't promote many scars or adhesions. So we are actually very used to, and I would say that the norm in our group is that all patients have previous abdominal surgeries. In that specific operation that you mentioned, potentially the sleeve gastrectomy would be maybe a better option in patients with this condition, but definitely that does not prevent anybody to have a metabolic and bariatric surgery. No, not at all. No.
Yeah, it may, and I would add that it may limit the type that someone might be a candidate for. I personally have had one person in my career who, because of severe prior pancreatitis, was not a good candidate for weight loss surgery, but that was literally one person out of many, many years. And so that was a particularly special case. And they actually, during their workup that I was doing, identified the need to be managed by other types of surgeons for the consequences of that severe pancreatitis. Karen, can you ask or answer a question? What are the effects on the person asked about gut health? I think it means more about bowel habits after weight loss surgery.
Yeah, I think a lot of people have concerns about that. And with the main two procedures that we do, the sleeve gastrectomy and the gastric bypass, we're not seeing changes in bowel habits. But what we do see sometimes is less bowel movements because less in, less out. But if you have irritable bowel now, chances are you still will have that after surgery, constipation, right around the time of surgery. Of course, there are some changes, either diarrhea, constipation, but eventually you settle out pretty much the way you were before the operation with our two main procedures. Some of the malabsorptive procedures that we mentioned briefly may cause some diarrhea or loose stools, and if you choose one of those procedures, the surgeons will talk to you a little bit more about that.
Yeah, and I think I'd like to add, especially with the SATI and the duodenal switch, there are specific dietary protocols you need to follow over the long term to help minimize that. Also, if someone starts off with significant constipation, they may be somewhat helpful to regulating their bowels in that situation. Now, another important question that I'll quickly answer: is it possible to lose too much weight before surgery and not be qualified? And the answer is, I've never actually seen it happen in terms of insurance not qualifying somebody who actually did lose a lot of weight beforehand. Some policies do have language in them like you shouldn't lose much more than the qualifying amount, but in practice, I've never had somebody be rejected because they generally just look at your starting weight when you first make your visits with the team. Another question for Jamie. This person's always on their feet at work, kind of always on the move and on the go. And they were curious how you dealt with that as a nurse who's always on the go in terms of staying hydrated and strategies around that.
Yeah, so I really, the biggest thing for me was the most important was making sure that I'm getting enough water in, as well as the protein. So while I'm at work, that's 8 hours of the day where I need to be doing something. And so I actually keep like a measured cup in my office that I know there's 12 ounces in it. And so I try to make sure like I get essentially 2 cups in the morning or before lunchtime down, and 2 cups in the afternoon down. So that way I know I've at least hit like 48 ounces worth of water so far in the day. And that way when I get home, obviously I know I'm going to be drinking something, having something to drink in the evening, as well as I keep water at my bedside. So I usually am never really worried about how much water I've taken in or fluids I've taken in. The protein, that's another thing, is just kind of learning how to incorporate that in your day. So like I rely on protein bars or protein shakes, just because like I said, I'm running around. I don't always have enough time to eat a lunch or eat something. I'm not necessarily hungry. And so trying to just maximize the amount of protein that you're actually getting in that serving is actually really important. Right after surgery, and it was like one of my first grocery shops, I knew my limit of how much food I can actually physically put in my body at one time was going to be limited. So if you think of an egg, and I was only able to eat one hard-boiled egg, well, one hard-boiled egg is only 6 to 7 grams of protein. And so just knowing like if I can't even eat a whole egg, then I'm only getting 3 to 4 grams of protein in that. So really just kind of looking at, what other options are there out there that are available, like the higher protein yogurts, things like that. If you can only eat half of a cup of higher protein yogurt and it's got 17 or 16 grams of protein, then you're still only getting 8 grams of protein in you. So just keeping track of that is really important so that you can hit that protein goal. And then your dietitian, when you meet with the dietitian, they actually will give you, there's a calculation of how much specific protein your body needs based off of your height and your body weight, things like that. And they'll give you that that number of where your actual specific goal is for the daily amount of protein that your body needs.
Thanks.
Mm-hmm.
Ricard, I'm going to hand this one to you. If a patient, and I'm going to hand it to you because I actually don't know the answer to it. This patient has tried some of the weight loss medications in the past, like Ozempic, that have made them significantly nauseous. Does this predict that they will have more nauseousness after weight loss surgery?
That definitely suggests us that the patient has this trend to be more nauseated than others. There is a little bit of evidence suggesting that definitely they will have a little bit more struggles. But as you know, one of the mechanisms that our operations have is to induce satiety and this lack of hungerness. So I'm not saying that that's intentionally, but definitely that is a factor that sometimes can be associated. So I would say that maybe she will have more trend to be nauseated, but at the same time, that doesn't mean that she will not be successful. That's what I was trying to say.
Yeah, I mean, not knowing any of the specific information, one thing I'd say to this patient is that nausea is the most common side effect symptom with weight loss medications like Ozempic, and so and happens very frequently, if not to almost everybody to some degree. Whereas with weight loss surgery, it's extremely rare to have a long-term issue with nausea afterwards. And so, this person's experienced a pretty common side effect or symptom, and that's a very, very rare one after weight loss surgery over the long term. I'm going to send this one over to Karen. This patient has a history of kidney stones and has previously been prescribed a lower protein diet because of that. How would you manage that, or are there certain surgeries we might recommend to for this particular person?
Yeah, so some of the studies have shown increased incidence of kidney stones after bariatric surgery. I'm not sure the mechanism of that is known, and it's not in all studies. So what we recommend is just being very vigilant about fluid intake after surgery. Make sure that you try to get 6 to 8 glasses of fluid and avoid those kidney stones. But I don't know that the evidence is strong at all that bariatric surgery influences kidney stones. It just may make it a little harder to get the fluids in afterwards. That can be a risk factor for stones. Feel free to jump in, and doctors, if you have any additional info there.
I think the main thing is, for me, it would steer me away from duodenal switch, because in that operation, there is a higher protein requirement after surgery compared to the other two for protein intake. And if you were been directed to be on a lower protein diet for any reason, whether it was stones or some other reason by one of your other physicians, you'd probably want to steer away from that one. Speaking of which, Jamie, can you speak about any food intolerances that you have? I think that's been several people have asked that question.
Yeah. So there are some things, and every person, like in my experience speaking with other people that have had surgery, it really just depends on your body, essentially, what foods you're going to be able to tolerate and what foods that other person might be able to tolerate. So some of my colleagues, they also have had the surgery, and they are able to eat something that to me, I'm not able to eat at all. Some of the things that I've noticed are like cereal. I used to be able to eat a little bit of cereal, and I wasn't really a big cereal person in the first place, but now any kind of cereal, I really haven't been able to tolerate it at all. It just makes me feel sick to my stomach. Rice, those types of things where it's like a grain, it kind of feels like it expands in your stomach and makes you feel full and just not really that great. I've heard some other people that depending on like the lean protein, so some people like steaks and chicken when it's cooked a little bit more thoroughly, they have a little bit harder time tolerating that. But again, that's just, each person's way that their body reacts to the surgery, essentially. Sometimes even like ice creams and things like that, like higher dairy products and certain protein shakes, they kind of made me feel a little bit more full, longer, maybe give me a little bit more of that nausea. But again, that's like that whole like up to 6 to 12 months where I talk about getting comfortable with your body's anatomy. Like during that time, when you're eating certain things like that, you're going to know right away, like, oh, I shouldn't have put this in my mouth. It's making me sick. And over time, continuing to try that, I've noticed, what, every time I've tried this, it's made me sick. I'm not going to have this anymore. It's just not worth it because I've felt sick from this. And so there are specific things where I don't even crave them anymore. I don't even want them because the way that it's made me feel after surgery has just kind of given me like that aversion essentially. And so essentially, usually 9 times out of 10, it's been something that I really shouldn't have eaten in the first place because it was, something that could make you gain weight or not really the healthiest thing for me. And so to me, I was like, well, pros and cons. I guess it's okay that I can't eat that.
Thanks. I'm going to answer a couple quick questions. Someone asked, is Ozempic the same as phentermine? They're definitely not. They work in very different ways. There's more and more different weight loss medications that are out there on the market that work differently. One other thing to know, if anybody is on here and is interested purely in medical weight loss, there's also, through the same department, we have that program. Another person asked the question, I'm on the medical weight loss program with you guys, and I'd like to move over to the surgical pathway. How would you like me to do that? And you can just let your medical weight loss provider know that that's something you're interested in. They can take it from there. The other way you can just do it is by going to our website and filling out the registration, because that will trigger a check on your insurance to see what your coverage is and to see what you would have to do beforehand for your insurance requirements. Looking through the rest of these questions, some people have asked about specific diet afterwards. Ricard, can you talk about the dietary progression?
Yeah, that's an important question. I think that our program is really strong in our dietitian follow-up and surveillance plan after surgery. So definitely patients, normally they stay what we call phase 1, phase 2 diet the first 2 weeks, meaning it's going to be basically clear liquids. On week number 3 to 4, they switch to a more consistent food, but meaning more puree-like food. But definitely what you have to understand, and I think that Jamie gave a perfect testimonial and summary, is that you will need to change your mindset. You will need to change the way that you live, the way that you eat, the way that you exercise. Everything is about motivation. And these 3 parts are, to me, the fundamentals of success. So we surgeons, to be honest with you, we think that we are great, but most of the job is on you. We do the operation, we boost your weight loss, but at the end, there are only 3 things that matters. 1, putting apart the surgery, of course, we boost the weight loss, but then over time, success is lifestyle changes, which means what sort of diet and how well you follow. And here we do a great job, and Karen can talk to you about how our dietitians follow up our patients. You will never feel that you are alone. that program is sometimes we are too painful to the patients because we used to reach out to them so often that they feel a little bit overwhelmed. And then the two main steps are lifestyle changes, exercising, and your motivation. Those three are the key points. It doesn't matter, to be honest with you. It does matter, but not is that important what type of operation. It's more how you adjust to your lifestyle changes and how your motivation is and how you change your behavior. Because if at the end of the day, if Dr. Gutnick, who is a phenomenal surgeon, does a perfect operation, but you try to keep eating the same, in the same way, you think that he's like a magician and you staying in your couch by yourself, not moving at all the weight loss will come. That's not completely true. So it relies on you most of the time.
Thanks, and I think we'll do two more questions as we're at around the end of our time. This one's over to Karen. How do these operations affect, the person says psychotropic drugs. I'm assuming they mean like drugs that a psychiatrist might prescribe. Are they affected by the surgeries? Do we change anything with them?
Yeah, that's an excellent question. A little bit of that, a lot of that actually depends on which procedure you choose. So with the sleeve gastrectomy, there's really not a malabsorptive component. We normally don't see any changes in medication absorption. With the gastric bypass, there's a small section of the intestine that is bypassed. So sometimes we do see some small changes in the absorption of medications. So in the specific incidence of psychotropic medications, it would depend on the number and type of medication that you're taking. We would work with you and your doctor individually on whether or not that would be a significant issue. The standard antidepressive, anti-anxiety medications are normally not an issue, but people who are on some of the more heavy-duty psych medications may need an adjustment there. So we would definitely work with your physician. Yeah, other medications, antibiotics, usually that's not an issue. You can speak more specifically, maybe Dr. Gutnick, to the DS and the SADI.
Even with those, the majority of medications don't need to be adjusted. Any particularly important medication for you, the main thing would be following carefully with the practitioner that prescribes it so that it can be monitored, and if adjustment needs to be made, it can be made. One final question, maybe we'll ask two final ones and then it'll be the last ones. I'll take the first one. Someone asked about gallbladder and gallstones after surgery. Gallstone formation can be caused by rapid weight loss, as you see with these operations. This is frequently asked question because back in the earlier days of weight loss surgery, gallbladder removal was a standard part of these weight loss operations. That was mostly because they were done in an open fashion and created a lot of scar tissue. Now that we do them laparoscopically, we typically don't remove your gallbladder at the same time because it can be removed down the road if it ever becomes a problem, and most people's don't. And so that's why it's not a standard part. It might be removed as part of one of the operations in a specific situation. I'm going to send the last one over to Dr. Corcelles. Can you talk about excessive skin after weight loss surgery? Does it happen to everyone? And what can be done about it if it's even necessary?
Yes, great question. So I have to say two things, Jesse. I will say that if our patient exercise, go to the gym, strength the muscles, do weight, the chances of skin falls is less than normally. But we have to be honest, and that comes, and it will depend on the initial BMI. So the answer is yes, but it depends on how the patient behaves. It's like a little bit what I was saying at the beginning. And if it's covered or not, the insurance world is a little bit unknown by myself. I think, maybe I'm wrong, and Karen will be annoyed about what I'm going to say. I don't think that it's usually covered unless there is a clear medical underlying condition that deserves the skin folds to be removed. Am I correct, Karen?
It's true. Yes, you're correct. It's very rarely covered. If it's causing a significant issue, so if your patient's losing in excess of 150 pounds, sometimes that causes rashes or other issues and it might be covered. We have a great team of plastic surgeons that can work with our patients after, but the average person does not require plastic surgery, so I don't want people to leave here thinking that's the case. Yeah.
Excellent. Well, thank you everybody for showing up today, asking great questions. Thank you to the panel for spending your time today to answer them and to present. As just a reminder, if you're interested in learning more, please go to our website. We have another actually different seminar on there that gets into more of the nitty-gritty details, believe it or not. There's a registration questionnaire which will allow us to do an insurance benefit check and let you know what your insurance requirements are. If you're someone that does not have coverage, we can also let you know what the self-pay options are. And again, please, everybody, please have a wonderful afternoon.
Bye.
Thanks everybody for connecting.